Dr. Anjali Malik, and I am a breast imaging radiologist in Washington, D.C. I detect and diagnose breast cancer, and I talk on my social media platforms and through organizations like the Society of Breast Imaging and Bright Pink about early detection of breast cancer and about identifying and reducing your risks for the development of breast cancer. So today I want to talk to you about some of that. I want to talk to you about your breast health, breast cancer, breast imaging, and beyond. So first up, let's start with some misconceptions about breast cancer that I hear all the time. Number one, I hear that breast cancer is a disease that only older women need to worry about, and that is false. So while age is one of the risk factors for the development of breast cancer, we know that it can happen in women in their 20s and 30s, and 1/6 of breast cancers happen in women in their 40s. So while, yes, we don't screen for breast cancer until our 40s, and postmenopausal women in their 50s and 60s are at higher risk for the development of breast cancer, it is something that younger women need to have on their radar and be mindful of. Another common misconception is that if you don't have a family history, you're not at risk for breast cancer, and that is absolutely false. So 75% of breast cancers are sporadic, meaning that they happen in women who have no family history. So again, incredibly important to be screening for breast cancer, even if you have no family history. Also on the family history, we have two more misconceptions. Number one is that women often think that they only have to worry about the family history on their mom's side or their maternal side. And of course, we are a 50-50 mix of our mom and our dad. And so our paternal family history matters as well. And then the second item is that women only know their family history of breast cancer. And while that is important, it's extremely important to know any cancer history in your family because other cancers can impact our risk for the development of breast cancer. Those include ovarian cancer, colon cancer, pancreatic cancer, and prostate cancer. So know your family history, know both sides of your family history, and don't let the absence of family history make you complacent. Another misconception that I often get is that the only thing that I can be doing as a woman is getting a screening mammogram. And while that is extremely important, and I absolutely recommend annual mammography for women over the age of 40, there are things that you can be doing, and we're going to be talking about some of those ways that you can be reducing your risk and impacting your breast health. And then when it comes to a cancer diagnosis, so many people think that cancer equals death and that cancer is their fault. And neither of those is true. So with early detection of breast cancer, there can be 100% survivability of the earlier stages of breast cancer. And cancer is multifactorial. So there are ways we can reduce our risks, but so many of the risk factors are non-modifiable, and so many of the risk factors are related to our family history and genetics. And we'll be talking about those, but I want you to know that if you are someone who finds out that they have breast cancer, it's not your fault, and what you need to be doing right now is finding ways to reduce your risk. So what are those risk factors for the development of breast cancer? Well, our top two are being female and aging. And no amount of Botox is going to change that risk, which is why you should tune in for the ones that you can change. But some of our other non-modifiable risks, or ones that we cannot change, our race and ethnicity. So women of Ashkenazi Jewish heritage are of increased risk. They often have the BRCA mutations. You might have heard of that mutation. Angelina Jolie does have that mutation and kind of catapulted that into the spotlight a few years back. As well as African American or Black women. So they, in addition to also often having the BRCA mutation, they do present at advanced and more aggressive stages, regardless of socioeconomic class. So a lot of research being done there, of course, a lot of health disparities that do need to be eliminated. But if you are of Ashkenazi Jewish or African American descent, you especially want to be mindful of other risk factors, want to be having open conversations with your physician. Then there is the onset of menses and the onset of menopause. So Breast cancer is hormone sensitive. So if this is a breast cancer, it's going to have little receptors on it that are amplified by hormones, estrogen and progesterone. And so estrogen and progesterone exposure increases our risk for the development of breast cancer. So if we start our menses early or we go into later menopause, that just means more years and prolonged estrogen and progesterone exposure. Not things that you can control, but things that you need to be mindful of when it comes to your risk. And then finally, radiation to the chest. And no, I don't mean a chest x-ray or that little monitor at the airport. What I'm talking about is if you are someone who has had mantle radiation from a lymphoma to the chest and you've had therapeutic high doses of radiation, then that does put you at risk for the development of breast cancer. So I've told you all of these risk factors that you can't control. So what are some of the things that you can control? Well, again, when we talk about hormones, there are, of course, oral contraceptives or birth control pills and hormone therapy, replacement therapy for those women in menopause. They are hormones that are coming from outside our body, and they do have impacts inside our body. But there are a lot of reasons that women take both hormone replacement therapy as well as oral contraceptives. So it's really important to be having that discussion with your doctor. Don't make any decisions without discussing it with your doctor first. There are a lot of great reasons to be on those medications, and sometimes the risk for the development of breast cancer is outweighed by other choices. So 2 ways that you really can have a huge impact on your breast cancer risk are actually maintaining a healthy weight and reducing your consumption of alcohol. So fat cells or adipose tissue actually produces estrogen. And again, that estrogen exposure increases your risk for the development of breast cancer. And alcohol has been proposed to have the same effect. So in addition to causing cell damage, much like it does in the liver, it can also increase the production of estrogen within the body. No amounts of alcohol have been found to be safe. Of course, everything in moderation, and there is the suggestion that it helps with women in heart disease. And so again, open discussions with your doctor. If you are at someone for particularly high risk for heart disease, they have said that perhaps 1 glass maximum per day, and even less is better. And then what are some things that don't impact our breast cancer risk? Well, deodorant is one. So, you might hear that the aluminum in deodorant can cause breast cancer, and that has not been proven. And then you get some questions for like when you get your mammogram, we ask you not to put deodorant on. And it's not because we're worried about what it causes to the breasts. It's actually what it does to the mammogram. So deodorant gets trapped in our skin, and it mimics some more concerning calcifications when it shows up on your mammogram. So we are not worried about women wearing deodorant. Wear it if you want to, or a natural one if you want to. It's more at the time of mammography that it causes some problems with the images themselves. And then underwire bras do not cause breast cancer. They might cause you pain, they might cause you some discomfort, but they do not cause breast cancer. And implants. So there is a rare type of lymphoma that can be associated with one type of implant called a textured implant. Those have now been discontinued. And I think for most women who might have had them placed, they've been contacted and potentially had them removed. But for the average implant, there is no risk for the development of any kind of cancer, inclusive of breast cancer. The bigger thing when it comes to implants is having them placed such that you are still able to get mammograms and we are still able to get a good view. The better placement is behind the muscle, so the pectoralis musculature, which lies just underneath the breast tissue. Placing an implant underneath those makes it possible for us to still do a good quality mammogram. And yes, you can get mammograms even if you do have implants. Depending on the kind of implant that you get, it might need some kind of imaging follow-up specific to the implant. Sometimes that happens with an MRI, and that would be discussions to have with your plastic surgeon. So we've talked about a lot of things that can cause breast cancer. We've talked about hormones. What are some things that can protect us well, breastfeeding, ladies. So for all of you that are staying up late at night with those feeds, know that 6 months of breastfeeding can actually reduce our risk for the development of breast cancer. Of course, fed is best, so do what works best for you and your baby. But if you are trying to have some extra motivation on getting through it, again, it can reduce your risk for the development of breast cancer. There's also been some questions about soy exposure. So previously, there had been some concerns about the plant estrogens or phytoestrogens that are contained within soy and whether they would mimic estrogen within our own bodies and would increase our risk for breast cancer. And the answer is no. So the studies have not been able to prove that. And so far, soy is part of a healthy, balanced diet. Of course, you want to go for the unprocessed soy options like tofu and tempeh and avoid some of the more processed items that are out there. And then one thing that I do like to touch on is pregnancy. So pregnancy before the age of 30 can actually decrease the development of breast cancer, whereas pregnancy after the age of 30 increases it. I don't put this in the modifiable or non-modifiable category because it is something that's hard to control. So it's just something to be mindful of. If you, for other reasons, aren't sure when to family plan, but you are in a position to be doing so before 30, this might be something that nudges you in that direction. But again, a lot of different factors when it comes to family planning. So not something that we can just as easily classify as modifiable or non-modifiable. So a lot of factors, a lot of information. What should you be looking for when it comes to your monthly self-exam? So first of all, when it comes to the monthly self-exam, I like to recommend to women that they do it once a month and mid-cycle. So mid-cycle, if your first day of bleeding starts, that's day 1. And the next time you get your bleed, that's day 1 of the new cycle. So however long that time frame is, you want to do it in the middle, because that's when our hormones have the lowest effect on our breasts, and therefore we're less likely to have hormonal influences and lumps and bumps that are actually just hormonally related. So you should be looking for a new lump. And the only way you're going to know what a new lump is if you know you're normal. So get to know your breasts, get to know what they feel like. Know that one side is not exactly like the other. You're looking for large changes. And then again, focal pain. So, breast pain is really common. It's most often due to hormones. It can be due to caffeine, and it can be due to the muscles and bones that lie underneath the breasts. So when I talk about pain, I mean one spot all the time, doesn't stop. I don't mean pain that comes and goes. I don't mean pain that's all over the breasts. I don't mean pain that's cyclic. I know that's uncomfortable, but ladies, that's not the kind of pain we're talking about when we're talking about breast cancer. So again, focal pain, one spot, doesn't stop. And again, even then, it might not be related to breast cancer, but it is something that you want to let your doctor know about. We also want to be looking for skin changes. So this is any discoloration of the skin, any dimpling where we start getting little divots in the skin that makes it look like maybe something is tugging it from underneath, any warmth or redness. And, if there's any, again, warmth, if it feels like it's infected, when you feel like you have a fever. And then nipple discharge. So with nipple discharge, there's a few questions that your doctor is going to want to ask you when it comes to that. So pay attention if you do have nipple discharge as to whether it comes out on its own or you have to push it out or express it. And the other thing is the color of it. So it can range anything from clear or milky or yellow all the way to having blood within the discharge. And those are just things that help your doctor and your radiologist when they are working up nipple discharge. Also, when it comes to the breast exam, know that it starts at the collarbone, goes all the way to underneath the breast to the chest wall, goes all the way in the midline to the sternum, all the way out to the side, and includes the underarm region. That's because all of this is considered breast tissue, and we do the tissue of the breast drains into the underarm region and can often have lymph nodes in that area that might be the first thing that a woman notices as a sign of breast cancer. If you do identify something, two things that I recommend. Number one, monitor it for at least a couple of weeks just to see if it changes. Now, this is not something that I want you to do every day. So if you feel something one day and you feel it the next day, you're not going to know if it changed. So if you feel it one day, you document it. You say, okay, it feels like it's moving. It feels like it's about 1 centimeter. This is where I feel it. About a week or two later, take another feel. You'll really have a better idea of if it's changed or not. It's kind of like if you see a friend after 6 months, you'll be able to tell if she lost weight versus if you're seeing her every day. Those changes are more dramatic and more noticeable, and it really helps us as your physicians know if something is changing or not. And then, of course, always let your doctor know if you feel something, and they'll determine when something needs to be worked up or followed. So when it comes to breast imaging, let's talk breast imaging. So screening mammograms are the way that we detect and diagnose breast cancer. And for an average risk female, these are performed every year starting at the age of 40. You might have heard a lot of different controversy, a lot of different recommendations, but the annual mammography performed starting at the age of 40 has a 40% reduction in mortality or death rates. And so that is what has been proven to be the most effective and reduce mortality for women. So what is a screening mammogram? It is where we take x-rays of the breasts in 2 different directions, and we use those to look for changes inside the breast with masses, with asymmetric breast tissue, with calcium deposits, with lymph nodes, and then we look at the skin. So these days, we're performing something called a 3D mammogram, which actually takes a series of images through both breasts and is extremely sensitive in its detection of small invasive cancers, which is what we want, but also decreases the false positive callbacks. So what are the false positive callbacks? Well, whenever anyone gets screened, there is the possibility that some things won't go on to be cancer, but they did look abnormal. Think about it like when you're going through the TSA security line. Not everyone that they pull aside has a gun or has a knife or has something that would be, harmful, but they have things, they see things that look like they could be funny and they just need to do a check. So it's kind of like that. Yes, it's inconvenient to have your bag checked and pulled apart, but in the end, it's all about safety and making sure that, nothing dangerous passes through. And that's kind of my job that definitely is my job as someone who's detecting and diagnosing breast cancer. So to give you some perspective, if 1,000 women get a screening mammogram, about 100 to 200 will be called back for additional imaging. Out of that, about 20 will go on to get a biopsy, and out of that, 5 will have breast cancer. So if you do find yourself getting called back, it does not mean you have breast cancer. It just means that something needs a little bit closer look. So just think of it as that TSA baggage screening that, they see something that looks funny, that, you didn't pack anything suspicious, so they just need to take a closer look. Now, I hear women say, well, I don't feel anything and I got a call back, but I don't think there's anything there. And the thing is, I can see things on a mammogram that are much smaller than you can feel. In fact, studies have shown I can see things that are smaller than a pea, but by the time you're able to feel them, they're about the size of a walnut. So those are, almost a centimeter or 2 apart in size. And that's why we do annual screening mammography for that early detection. So on that early detection, I referenced this earlier, but just to talk about it again, the survivability for women who do have breast cancers that are found at stages 0 and 1 go on to 100% survivability versus those who are detected at stage 4, which is 20% survivability. And it's not just the decreased mortality rate and the increased survivability. It's actually some quality of life issues. So the surgical options are greater when a lesion is found earlier and smaller. So it might mean a smaller surgery. It also means better cosmesis or better cosmetic results, which sounds superficial, but again, it is one of the really important outcomes that we're looking at. And every surgery has its risks. So we really want to be doing the least invasive, the smallest, the shortest, the quickest surgery possible to effectively treat you, but also minimize any risks. And then earlier cancers might not have to have as aggressive forms of treatment, which in and of themselves can have many side effects. So early detection is always the best, and annual mammography is the way to do that. So you might have heard about breast density. What does that mean? What does it mean to have dense breasts? Why do we talk about density? Well, mammograms, again, are x-rays of the breasts. And on x-rays, things show up as black or white. You might have seen a chest x-ray or you might have seen a mammogram. Well, the things that show up as white on the mammogram are tissue, but also cancer can show up as white, whereas fat shows up as black. Now, yes, we talk about obesity, and yes, I said that fat cells, you want to minimize them. But inside the breast, no fat means only tissue, which means it's harder to find cancers since they show up looking the same as tissue. So the proportion of our tissue to fat is called our breast density. And we categorize it into 4 categories, from fatty to scattered tissue to heterogeneously dense tissue, which means you have about 50 to 75% tissue, or extremely dense, which means you have greater than 75% and oftentimes almost 100% tissue. And those last 2 categories are going to be when it's harder for us to detect breast cancer. So it's mandated in most states, but not all. So know the laws in your state. That radiologists, when we read your mammogram, we have to inform you of what your breast density is so that you're aware, and you can have a conversation with your doctor to see if you need to be doing something in addition to your screening mammogram. What are the things that you could be doing in addition to your screening mammogram? Well, 1, ultrasound. You can be taking another look at the breast with ultrasound. And number 2, if you are at extremely high risk, you could be considering adding a breast MRI into your screening regimen. So a breast MRI gives IV contrast in the arm, and it's taken up in areas of increased activity. So it's not something we want to be doing on everybody because it's expensive. It has contrast, which has its own complications, but it's really good for women who are at extremely high risk. So how do we calculate risk? Well, the 1 in 8 women that you hear that statistic a lot, that is about 12%. So the average female is at a risk of about 12% over the course of her lifetime. Those are the women for whom an annual mammogram at 40 is appropriate. But for women who are at increased risk based on their family history, based on a known genetic mutation, or based on a combination of a variety of calculations and factors, they are the ones that might require those additional tests, particularly if they have dense breast tissue, because not only does dense breast tissue make it challenging to interpret our mammogram, but it also can slightly increase our risk for the development of breast cancer. So again, so important to be aware, to be involved, and to be having those conversations with our physicians. So ladies, what I want you to leave from here today is know your breast density, know your risks, know the risks that you can reduce, know your family history, and know if you need to be getting genetic testing or adding any additional screening other than starting your mammograms at the age of 40. So I welcome any questions that you have. You can find me on Twitter and Instagram at Anjali Malik MD, and on my website, anjalimalikmd.com. Ask me all your breast health questions, and I look forward to hearing from you.